So I think with that, I will wait and see and not be too fixated about guidelines and studies at the moment. There's still a little bit of angle for individualization. So I'm going to move on to the last talk by Professor Wang from Taiwan, who's going to switch tracks again a little bit more to talk about microvascular flow. Professor Wang, please.
Thank you for your sharing. Ladies and gentlemen, good afternoon. I'm Yu-Chen Wang from Asia University Hospital in Taiwan, and it's my honor to be invited here to discuss about the strategy for the STEMI patients with TBG5 and what we can do. About the thrombosis burden scales by coronary angiography, the TBG grade 5 means the definite complete thrombotic occlusion of the vessels, which also means the TMI zero flow. Okay. And the previous studies show that in STEMI patients with high thrombosis burden, they will have a higher rate of adverse outcomes, including the cardiovascular death, cardiogenic shock, deafness, and stems from heart failure or even stroke rate. And STEMI patients with TBG grade 5, they also show to have an increased mortality rate comparing with the patients with lower thrombosis burden. And since the COVID-19 infection spread all over the world since last year, it's interesting to see that many studies from single center observed that the thrombosis burden was high in STEMI patients with confirmed COVID-19 infections. And there is also another study showing that STEMI patients with concurrent COVID-19 infection has a higher thrombosis burden compared with STEMI patients without COVID-19 infection. And so what we can do for TBG grade 5 for STEMI patient? The first reasonable strategy is to do the thrombosis aspirations. And I believe that many physicians will tend to do the manual thrombosuction when they see there is a large thrombosis burdens by coronary angiography. And with the thrombus aspirations by thrombosuction catheters, we can remove the thrombotic materials rapidly from the coronary arteries, which will allow a superior visualization of a residual stenosis, and which may facilitate the direct stenting strategy and result in better clinical outcomes. And previous studies in real world, the high thrombus burden was associated with the use of the manual thrombus aspiration. That means we physicians tend to do the manual thrombus aspirations in high thrombus burden patients. And there are 3 major clinical trials to study the efficacy and the safety of the thrombus aspiration in STEMI patients. There are TABAS test and total studies. In TABAS studies, which enrolled more than 1,000 patients, which show that the thrombus aspiration result in a better myocardial blast rate and a better ST segment resolution rate compared with patients with in control groups. And after 1 year's clinical follow-up, a patient receiving the thrombus aspiration also showed to have a lower total mortality rate compared with the control group. And another larger studies, the test trial, which enrolled more than 7,000 STEMI patients. And however, in these studies, the patients receiving the thrombectomies failed to show the mortality benefit after 1 year, after 30 days follow-up, compared with the PCI alone groups. And about the secondary endpoints, including the stent thrombosis rate, the thrombus aspiration also failed to show the clinical benefit. And even after 1 year's clinical follow-up, patient receiving the thrombectomy also showed no benefit about the total mortality rate. And the largest clinical trial is the total trial, which enrolled more than 10,000 STEMI patients receiving a primary PCI. And in these studies, patients receiving the thrombectomy also showed no clinical benefit about the primary composite endpoint compared with the PCI alone groups. And about the secondary endpoints, including the cardiovascular death, recurrent MI, cardiogenic shock, or the class 4 heart failure patients, the patient receiving the thrombectomy also showed negative results compared with the PCI alone group. And it's worth of noticing that patients receiving the thrombectomy even have a higher stroke rate compared with the PCI alone groups, which may be due to the procedure, the operator's procedure, if they are familiar with that. And about the subgroup analysis in total studies, even in patients with higher thrombus grade, more than 3, the thrombectomy even failed to show the clinical benefit in these high-risk groups. And another, in addition to the manual thrombus aspirations, the angiojet mechanical aspiration is another way for better to have a better efficacy to remove the bulky thrombus, which use the burning effect to create a vacuum effect to have a greater thrombosuction effect to remove the bulky thrombus. However, the STEMI studies show that in compared with the control group, patients receiving the angiojet have a higher total mortality rate and a higher MACE rate. In contrast, in the Just Dance trials, a patient receiving the angiojet thrombectomy prior to the direct stenting showed improved clinical outcomes in STEMI patients. And another small randomized control trial, the SMART trials, which enrolled only 80 STEMI patients, show that for patients receiving the angiojet thrombectomy, they will have a better final TIMI flow rate, better final TIMI brush rate, and better early ST segment resolution rate compared with the control groups. However, in meta-analysis, the mechanical aspiration for the thrombus aspiration is not beneficial in reducing clinical outcomes in STEMI patients. And besides, the angiojet thrombectomy is rarely used right now in clinical practice due to the reasons as below. First, the setup is more complex. The second, it may result in some adverse events, including the advanced heart block or hypotension. Besides, the data in clinical trials or meta-analysis didn't support the clear clinical benefit. And finally, the most important, the cost is significantly higher than other strategy or other method. So about the international guidelines, the 2015 ACC/HA guidelines give a class 3 recommendation for routine aspiration thrombectomy before the primary PCI. Similarly, in the 2017 ESC STEMI guidelines, routine use of thrombus aspiration is not recommended, and which is the class 3 level of evidence A recommendation. And in Taiwan, about there is a 2020 focus update of the STEMI guidelines. And in this guideline, the thrombus aspiration during primary PCI is an optional but not a routine procedure during the primary PCI. And however, should we stop the thrombectomy totally? I think it may be still beneficial when performed selectively in patients with high thrombus burden because it allows direct stenting and may reduce the distal embolization, even though it may increase the stroke risk if the operator is not familiar about the procedure. So about the recommended algorithm for the thrombus aspiration, if we base the STEMI patient with TBG5, and then we should pass the guide wire to do the pre-dilatation with a small balloon, and then to evaluate the thrombus burden. If the thrombus burden is moderate to large, then the thrombus aspiration or even the bailout use of the angiojet may be considered for the further intervention. And another strategy is the deferred stenting strategy, which is a two-step revascularization approach. The first step is the prompt mechanical restoration of blood flow via the blood balloon dilatation and or thrombus aspiration. And after that, we may defer subsequent stent implantations either a few hours or days from the index procedure with a concomitant and anticoagulant and antiplatelet therapies. And in this case report, there is a heavy thrombus burden in proximal LAD with stenosis at the index procedure. And after 5 days of antithrombotic therapies, the repeated and coronary angiographies showed the complete resolution of the thrombus. And in this way, we can implant the stent more precisely. And about the advantages and the disadvantages about the deferred stenting strategies, the advantages include that it may lower the thrombus burden, decrease the pre-procedure MI, improve the TIMI flow, and prevent the slow flow or no reflow, and it may even allow larger stent size, allows lesser numbers of the stent implantation, or even reduce the infarction size. However, about the drawback of the deferred stenting strategy, it may result in coronary reocclusion or unplanned revascularization, or there may be the increased bleeding from the extended anticoagulation therapies, or there may be increased medical costs. for these strategies. And the deferred STEMI trials enrolled 100 STEMI patients, which showed that the deferred STEMI strategies reduce the no reflow or slow flow in STEMI patients with improved myocardial salvage in high-risk STEMI patients. And another similar trial, a single-center studies trial, showed that in STEMI patients with high thrombosis burden, deferred STEMI strategy reduced no reflow or slow flow, but did not reduce the incidence of major cardiovascular events. And another large clinical trial, the Dynamic-3 deferred studies, which enrolled more than 1,200 STEMI patients, show that in patients with the deferred STEMI strategy, it fails to show the clinical benefit compared with the conventional groups. Besides, patients with deferred strategy also fail to reduce the all-cause mortality rate, recurrent myocardial infarction rate, or the heart failure hospitalizations compared with the control groups. And furthermore, the meta-analysis also showed that even though the deferred STEMI strategy results in low rate of slow flow or no reflow only in the observational studies, but not in randomized controlled trials. And the meta-analysis also failed to show the mortality benefit or the MACE benefit in patients with the deferred STEMI strategies. And about the possible reason about the discrepancies about the current studies, the first one is that the deferral intervals from the initial reperfusion to stent implantations vary considerably between studies. And the second one is that in these trials, the study population varies a lot. There is a heterogeneous population. For example, in the deferred STEMI studies, and in most observational studies, they enrolled high-risk STEMI patients with high thrombosis burden. However, in the Dynamic-3 deferred studies, it's an all-comer trial, so the result may be different due to the different study designs. Therefore, in the 2017 ESC STEMI guidelines, the routine use of deferred STEMI strategy is not recommended, which is the class 3 level of evidence B recommendations. However, I think the deferred STEMI strategy should still be considered in selected patients, such as patients with high thrombosis burden, or patients with long lesion, or patients with high risk of slow flow or no reflow. For example, in patients with high STEMI score, or in patients with baseline TBG 0 flow, or in patients with cardiogenic shock undergoing IBP support, or in patients with whose reperfusion time is longer than 6 hours. In these high-risk patients, the deferred stent strategy may be considered. And about the other strategies for STEMI patients with TBG5, there are some, for example, the glycoprotein 2B3 inhibitors, or the distal embolic filters, or the distal protective devices. About the 2B3 inhibitors, the meta-analysis showed that compared with the IV and IC administrations, the IC administration of the glycoprotein 2B3 inhibitor may result in better TIMI flow, target muscle revascularization, and shorter mortality rate after PCI. However, there is a lack of the data about the mid-term to long-term outcomes comparing with these two approaches. And there is also no evidence to recommend the routine use of glycoprotein 2B3 inhibitors for primary PCI. Therefore, the 2017 ESC guidelines give a class 2A and the level of evidence C recommendations that the two glycoprotein 2B3 inhibitors should be considered for bailout if there is evidence of no reflow or thrombotic complications. And about the distal embolization filters, there are many different devices in the market. However, trials about the filters failed to show clinical benefit previously. And there is also some distal protection devices. Similarly, there is no clear clinical benefit about the clinical trials to show the benefit of the distal protection device. Therefore, about the take-home messages. First, the high thrombosis burden, including the TBG grade 5 in STEMI patients, predicts poor clinical outcomes. Routine use of the thrombus aspiration or deferred stenting in STEMI patients is not recommended by international guidelines due to lack of study evidences to show clinical benefits in all population. However, the thrombus aspiration or deferred stent strategy may be used selectively in STEMI patients with high thrombus burden to get a better chronic blood flow. Glycoprotein 2B3 inhibitors may be considered for bailout if there is evidence of no reflow or thrombotic complications. Finally, the further larger and well-designed clinical trials are still necessary to find the best interventional strategies in STEMI patients with TBG5. Thank you.
Thanks, Yu-Chen. That was a fantastic and very comprehensive review of everything negative about high thrombus burden in STEMI. Thank you very much. Can I ask for any comments or questions?
I have a comment, Jack.
Please.
Hi. Yeah,
Hello.
so I think that was a fantastic talk, really learned a lot. But I think the key word here is routine and in special circumstances, right? Like routine use of thrombus aspiration catheter is not recommended. But like in Bangladesh, where the patient comes with the onset of chest pain and then the first medical contact, it's like hours. Like in the Western world, they just press the telephone and 911 or something, and the ambulance comes and the patient goes to the hospital. They don't really have much thrombus burden. But in Bangladesh, you know, the patient will wait and see if the pain is going to go away, take some antacids, and then eventually someone decides, no, it's a bit more serious than indigestion, so let's go to the hospital. And it's already hours. And usually by the time the patient comes to the cath lab, there's quite a bit of thrombus burden. And usually in our practice, we have to use thrombus aspiration catheter more frequently than is seen in the Western world. So I think, you know, the practice differs from country to country, from patient to patient, but that's a great talk. Thank you.
Further comments, Prof?
Thank you, Jack, for giving us a chance to comment. Actually, may I ask the presenter a scenario? Suppose somebody came with infra-MI and you go for primary PCI, then he found that it's ectatic vessels with huge thrombus burden. Obviously, in this situation, you may not have the right size of stent even, but then again, are you planning to do some thrombosuction there or no thrombosuction, just a medical management, or proceed on with just balloon angioplasty? What will be your recommendation?
Yeah, thank you for your good questions. I think actually there is the real world clinical scenario varies individualized. So I think there is no well-designed, really well-designed study to compare different scenario, or for example, different reperfusion intervals about the thrombus aspiration strategies. So I think even though the guidelines didn't recommend routine use of the, for example, the thrombus aspiration strategy. However, I think we will do it. It should be arranged individualized, especially in high-risk patients. For example, if the reperfusion time is very long and the thrombus burden is very high, I think we should use the thrombus aspiration, or even with the aggressive antithrombotic or antiplatelet therapies to reduce the thrombus burden.
Dr. Jamil?
Thank you, Dr. Yu-Chen.
I have a question.
I am Professor Mir Jamal, and your entire talk is excellent, very nice, and entirely under evaluation, as because whether we shall give thrombosuction or not in primary PCI, you have shown already. We know that it is class 3 indication, but sometimes we require and we do. Regarding GP2B 3A inhibitor, and that is class 2B 2A indication, but sometimes we require and we also get good result. Regarding the deferred stenting, we usually do not do deferred stenting, but very rarely, once in a year or once in a month, we have to defer due to the so much thrombus burden that there is no landing zone we can discover, and that is why we can defer. And so the entire space is new to us, as well as exploring to us to know and further know regarding the guideline, and we shall have to wait all to solve all this issue for the next guideline. Thank you all.
Thanks, Dr. Jamal. Last question, please, before we have to end the session.
Thank you, Yu-Chen, Wang, Professor Jack,
Excellent
hand raised from Dr. Fahim.
speech.
Can you-
I am practicing.
Savinasham raised hand.
Sorry, I think there was a little bit of breakup.
I'm speaking. Yeah. I'm sorry. Can you hear me? Am I audible?
Savinasham.
Yes, yes, please go ahead.
So it was rather a comment that there is a routine in a guideline. The latest guideline they have mentioned that routine use of thrombolysis is class 3, but it was also written that you can use it in high burden, high thrombus burden, and also if there is a bailout procedure, you can use it. Number one. And my next question to Yu-Chen Wang, that you meant this breakfast strategy. I want to know, do you use an antithrombotic like streptococcus and then do the PCI afterwards, or you do only use heparin? And another question, if a patient comes, we do pharmacoinvasive procedure a lot. So when a patient comes, you give us streptokinase or chenectipase, and then next day you go for a procedure. If there is a high thrombus burden, big thrombus, so what is your procedure? What do? You do thrombosuction then, or you do any other procedures like beta laterectomy or any laser procedures? Thank you.
Thank you. About the medical controls for patients with very high thrombus burden. Sometimes in patients with, for example, the affected RCA, due to the basal size is very large and the thrombus burden is very heavy. So we cannot do the. First of all, we will try to re-establish the TBG flow as possible by, for example, by the thrombosuction or the small balloon dilatation. And then I will usually use the deferred stent strategy in this scenario. I will just use the antithrombotic therapies, for example, the aspirin P212 inhibitor and the heparin. And sometimes we will also try to use the enoxaparin, because in sometimes trials the efficacy of the enoxaparin is better than the heparin. And usually after 3 to 5 days later, we will do the repeat the coronary angiography to see if the is lower. And at this during the secondary procedures, sometimes we can see the standard landing zone and see to do the more precise stenting strategies. And so sometimes, however, in some rare cases, for example, in some patients with hypercoagulable diseases, for example, for some patients have thrombocytosis, and he suffered from STEMI with a large thrombus burden at a very young age. And during this time, sometimes even so, after repeated thrombosuction and repeated just even with thrombosuction with angiojet or with prolonged anticoagulant, there is still some thrombus remained in the coronary arteries. In this way, I may try the prolonged triple therapies, which means the aspirin, P212 inhibitor, and sometimes the enoxaparin. And some of my colleagues try to use the NOAC. However, they are off-label use because there is no guideline or no clinical trials to clarify this kind of scenario.